are there any new advancements or new techniques in detecting kidney disease that have happened recently that you can share with us?
Yeah, well, there are a few. Some of which are a little bit outside my wheelhouse, but because as a clinical geneticist, we tend to focus in on certain types of disorders. But new biometrics, new wearable devices. There's lots of new technologies that are helping to monitor and detect early. And you can also detect it at a more of a population-wide level by looking at larger data sets that are available to say, well, okay, we've done a kidney function test and this patient has their kidney function been followed up and how can we follow that up? So there's all that going on, which is excellent. What we do a little bit more is on the diagnostic side for the typically rare single gene disorders, and that's come a very long way in the last 10 years. It was only 20 years ago that we encoded the human genome. Remember that in the turn of the century, and that Human Genome Project cost roughly $30 billion to do, and took many years and many labs and huge collaborations, which was a triumph of science at the time, really. These days you can sequence someone's genome for about $1,000 in 3 to 5 days. Not that you need to do that all the time. And it's become a clinical grade test. So this is not a research test. This is a test that you do in a clinical setting, and including in sick babies in the ICU. So that if they have poor kidney function, they can be seen now and get a result within a week for the families to say, is the cause of this baby's kidney disease due to a single gene disorder or not? And we can get an answer in 50% of the cases or more in that scenario, because we know the majority of causes are those single gene causes. What's actually harder are the complex multifactorial disorders, because in a way you've got to find lots of little changes. It's not one big change in the genome, it's lots of little changes in the genome, plus non-genetic factors, and put all those little pieces of information like a puzzle back together and say, well, this is the whole story for that patient. That sort of test is quite a long way away. There are polygenic risk scores coming for some conditions, so they do have some early polygenic risk scores for chronic kidney disease, but it's still early days, and it's some way away from being able to give patients with those types of kidney disorders a complete answer as to why they've got it. It's a really important question medically, and we're getting better at being able to diagnose it precisely, but it's mostly in the rare disease and single gene disorder space that we're able to do that.
Wow. It still sounds like we've come a long way in a short amount of time.
Yeah, too fast for most health systems.
Okay, we'll just move into some treatment questions, guys. So I don't mind who takes this one, if it's Caroline or Lisa. What are the current treatment strategies for CKD, and how are these personalised? I don't know, it might even go back to you, Matthew.
Yeah. Well, yeah, that's exactly why we need a diagnosis for rare disease. Because personalised medicine needs a personalised diagnosis. That's a cornerstone of all good healthcare, is knowing what's going on. Etiology or cause of disease is the building block for any treatment. You can treat generally, and you have to be pragmatic. If someone needs to go on dialysis, they need to go on dialysis. But the earlier question can and should be is, why were they getting kidney failure in the first place? Is there a process we can target there? And obviously that answer is yes for diabetes. For intrinsic kidney problems like untreated hypertension, that's another good yes. But it's often more complex. A lot of times we don't know why someone's got kidney disease. And sometimes it's due to an undiagnosed rare disease, so that's kind of what we focus on. We found that that's true in about 1 out of 10 adults even with kidney disease. It's closer to 90% of children who are on dialysis have a rare disease of some kind that's diagnosable. So once you do that, then all those possibilities of treatments open up. Unfortunately, there's not many rare disease treatments. That's something that is changing, and we hope it continues to change rapidly. But there are targetable medicines for some of those rare conditions that are coming online, and there's a lot of new trials on the way as well. So that's a very active area.
Did you have anything to add to that, Lisa?
Oh, no.
No worries. In your experience in the hospital, what has been the most significant advancement in treatment that you've noticed in recent years? So how are your procedures in implementing treatment?
Actually, probably the most recent sort of advancement in treating sort of early kidney disease has been some significant medicines. I think they're probably called the Flozins, and they've actually usually used with diabetes, but in the clinical trials that have been done, especially in the last 10 years or so, they've shown that they have significant effects for the heart and also the kidney. And so that's really, really important, because we can use those agents early on, and that will prevent or will delay the progression down to people needing dialysis. So we're hopeful in a few years that we won't see as many people coming on and needing dialysis because of these particular medicines. And that's really been one of the biggest, I think, most significant thing in the last few years. Would you agree?
Yeah.
Yeah. I guess also when you look at the technology and things that we use when we dialyse people, we're always looking at getting new machines, new shiny machines that do things a lot quicker and more efficient and a lot safer for patients, which is good for us as clinicians using them, and for the patients in particular. We're also seeing use of remote monitoring, so we can set some people up on dialysis at home and we can remotely monitor them. So that's also a really significant thing that we're seeing and using, hopefully. Yeah.
Great. Fantastic. Yeah, I was going to ask Caroline a question. So how can multidisciplinary teams, which includes psychology, how can they improve patient outcomes for kidney disease in the future? How do you see those roles working together?
So it's, as you're probably aware, it's a complicated condition that you're hearing about, and there are various stages that you go through if your disease progresses, and at every stage you need a next set of information about how to make a decision about what sort of treatment you're going to have, what sort of medication you may need to control the symptoms you've got. And so you do need a broad support team, and the multidisciplinary team in renal comprises the doctors, your very skilled nurses. It includes psychologists, social workers, dietitians, renal pharmacists, who are all experts in the impact of the specific diet or conditions that they can help you with, so that you can improve your self-care and better to learn and then know how to manage your condition to prevent it or slow it down from progressing. And then they're also there, should you be unlucky enough that it does progress and you need more information about, okay, what am I looking at next time for medication effects, side effects, treatments? Do I need dialysis? What sort of dialysis will I have? Will I go in centre and have the one in the arm? Will I have the one in the tummy? How can that be done? Can it be done overnight? There's all these decisions you have to make, and you need to gather information and feel confident to be able to do that with our help, so that you can make the best decision for you, your experience and how the disease is impacting you. Yeah? It's a very personalised experience, and it can affect your whole way that you're living. So it's important you feel confident you can get the information when you need it to make the next decision.
Thank you very much, Carolyn. So Lisa or Matthew, for this one, what promising research or technologies do you believe will shape the future of kidney disease or management?
I could just say one other thing.
Yeah.
Because I did a bit of a Google search before this afternoon.
Dr. Google?
I did, yeah. Because some of the clients that come in, when they talk to me about, when they come in and have a chat about their education and what's coming up, so they've also done a little Google search, and some have come up with this thing called the implantable kidney. And I think that's going to be the way of the future. But it's been sort of talked about for a long time, and it's all being developed in I think in America. And but I don't think they're actually anywhere near to clinical trials yet and anything. But I think that would be pretty amazing, because that would mean that there would be less people needing dialysis and transplant, and I think that is really the way.
Wow.
That's what I think is pretty exciting.
Yeah, there's I believe there's a debate amongst some of my colleagues about whether that implantable device, the first one that'll come, is an artificial device or something grown from your own cells.
Oh, wow.
Yeah, so the race is on whether it's biological or artificial.
Would there be a combination of both?
Most likely, yeah. So it's like, as always, it's not a black and white answer. So everyone will be correct on that bet. I think.
Yeah. Wow.
But there's still ways of approaching that answer too, right? Is the advancements in treatment when you get to the point of dialysis, and there's a lot of patients where arguably you want to treat it, and you can retire the dialysis machines and only need them very occasionally because you're treating the primary cause so much better. But dialysis is really needed.
Yeah.
And that is something else that's quite tricky, but is showing some promise.
Karen, I'm going to come back to you specifically on these ones. So just specifically about the psychological impact of CKD, in your experience working with the renal medical outpatients team, what are some common psychological challenges that patients face, and how can they be effectively managed?
Yeah, the big one is uncertainty. People come in and they're not sure of what they've got, how they've got it, what's going to happen to them, what are the treatments for it, how long, how it's going to affect their ability to work and do things that they like to do. And quite often that sets up, fear and uncertainty. It's a threat of the unknown. And you can become very stressed. Anxiety is quite common. In fact, it's very common as the disease progresses. Rates of anxiety and low mood, depression can affect a lot of people with advanced chronic kidney disease. In fact, almost double the amount of what it is in the normal population. And that's a factor of, it affects your whole way of being. So, fear, uncertainty, anxiety, low mood, grief. Grief is a big one. If you can no longer take your boat out and go sailing, and that's what you love to do, and it is now too hard to do it, it really can throw you off kilter. That was the thing that you did. And so people have to, certainly I work with them to work out, what do they value, what's important in their life, what are their goals moving forward, understanding that what they've done previously is probably going to have to change or cease to be. How can we move you forward? So I guess the psychologist's role is to help people get unstuck, because you can get very stuck. And it's all about, the whole team are supporting you to help you accept the condition and to provide you with the tools to be able to help you cope with it and adjust to it. And if you can do that, it can be very slow work for some people. And if you think about what anxiety is, fear of the unknown and the future, and you get caught into that, what if this happens, and then what if that happens, and what if that happens, and you're spending all your time worried about what's happening in the future. Or you get stuck at the other end where, I can't do this anymore, or there's no point in taking my meds because it doesn't make me feel any better, or I can't see any positive outcome, I'm still going to need to. You're into this very negative self-talk, and then I'm a burden to others, I can't provide for my family. So people get stuck between depression and anxiety, and it's my role to help them come back to what can you control. You can control your present. It's just how you adapt to that. So that's, I guess, what my role is.
Wow. I've just got one more for you too. Your role as a psychological support in improving their treatment outcomes and overall quality of life. Does it bring you down? Do you find that a challenge for you?
Yeah, it's hard to see people suffer.
Yeah.
And, you know, some days it's easier to help people than other days. And I often say to people, you know, these aren't people that I'm seeing. Psychologists normally, in private practice, you'd be seeing people coming in with mental health care plans. They've got a mental health condition. I'm seeing people, normal people come in that don't have mental health conditions, or many of them don't, and they've just got a crap condition. And it affects them significantly to the point where if you don't have a mental health condition, you may very well experience symptoms of what it might be like to have one. I like to try not to diagnose mental health conditions because I feel it is more of an adjustment disorder and a process people have to go through in order to work out how they're going to move forward. But yeah, it can be tough sometimes. And because it's a chronic condition and you're going to be stuck with it in various ways, shapes and forms, we get to know you very, very well. We get to know your family, you know, we get to know your carers if you come in with a carer. So we're there for the long haul. So yeah, we get very excited when we hear people have had a transplant and they're doing well and we don't need to see them at dialysis anymore. But we also get, you know, upset where things don't work out so well because we do know you. We do care.
I might go over to Matthew now for a couple of specifics as well. So, Dr. Wallis, or Matthew, sorry, your study that you've done with us provides significant insights into genetic renal disease and chronic kidney disease. Could you elaborate how genetic factors are influencing the prevalence and treatment of kidney disease in Tasmania?
Yeah, well, mostly what we did and are focused on doing, at least in these early stages, is that we need to understand how prevalent it is, firstly. And I think that it's been generally underappreciated how common single gene forms of kidney disease are because they haven't been diagnosed, or indeed were not even diagnosable 20 years ago. So part of the issue is that a lot of the data is older and historical, so the prevalence rates are lower than what they actually are. And that's something that we identified through that project, that actually the just talking rare disease generally speaking, it affects, though if you think about a rare disease, obviously it's uncommon, it's rare, it's not very prevalent, but when you think about rare diseases as a group, they are collectively common and affect about 6 to 8% of the population. And of people on dialysis, in adults, it's likely at least 1/3 have a diagnosed or undiagnosed rare disease. Once we understand that fully in Tasmania, I think we'll find it's probably a true number and might even be a little bit higher because a lot of conditions have only been discovered in the last few years. So we've got 20,000 odd genes and a lot of them have been linked to a condition of some kind when the gene isn't working properly. And the list of those morbid or known disease-causing genes is about 7,000. Wow. So 7,000 of 20,000 have a condition linked to them. So arguably, half of the box is unopened. Yeah. All of those genes won't necessarily be disease-causing, but there's undiagnosed types of rare kidney disease out there. So it's possibly higher. I guess the other aspect to that question is what do we do next? And what we need to do next is understand the impact for that particular group, because it seems to be quite high in that if you remain undiagnosed, that's going to impact your healthcare, especially when it's measured over several years. So identifying the impact of not having a diagnosed rare kidney disease or diagnosing it earlier and what impact that has are some of the next stages we'll go with the research. That's just one narrow aspect to the question though.
Lisa, I'll move on to you, if that's okay.
Yeah.
From your hands-on experience working with kidney patients daily, how important is patient education in managing kidney disease, especially when it comes to making their informed decisions?
Oh, it's vital, absolutely vital. That's my role and within the Red Unit as a chronic kidney disease educator and nurse practitioner. That is my focus for when patients come through the unit and they're part of our big team. Patients that need some information about chronic kidney disease, we see them and we talk about all these risk factors and how they're managed and how they can work with us to actually make them be sort of managed a little bit better. And what they want to do. And also one of the other bigger things that that we do is help people through the decision-making process about what treatment options they would like, they would prefer. I don't think anyone likes, but their preference for them if their kidney should fail down a track. And that can be a very significant education process, and usually myself and my colleague Emily, we can take significant time to actually work with someone. It's not all about facts and figures most of the time, it's about really what type of treatment option would actually fit that person the best for their lifestyle, because everyone's different and everyone has different values and different needs, and so one treatment option is not the same for every single person. And that's the beauty of what we do, is we work with someone to help them through that decision maker process to make the best decisions for them and their family. And we actually work as a big team, so it's not just us doing the education, everyone, all the people in our team have a significant component of education to their role.
So on that, it's a great segue actually, because you're currently working on a great project with Mathew Joes. So Carolyn and Lisa work on the Foundation's Lowenfeld Muller grant, and it's looking at the health decision making for those living with chronic kidney disease in their last 1,000 days. So I'll hand it over to you guys to run through that project.
This project is actually called the last 1,000 days of chronic kidney disease, supporting treatment decisions. Where? Up. Oh,
this side.
Whereabouts? Up
Come
here.
over this one.
Up over here. Sorry. That's 1,000 days of chronic kidney disease, supporting treatment decision making for Tasmanians, and it's a project that it's really about decision making process and how we can help people to actually go through that process. And so what do we know? We know that consumers living with chronic kidney disease clearly value outcomes beyond survival. So it's not just about how long we live with dialysis, it's actually what that life looks like with dialysis. And that's really informed with a big project that was actually an international project. It's called the SONG project, or SONG research project, and it's about 1,000 people were involved with that, over 70 countries, and it involved not only consumers, their carers, health professionals, and they came together and they looked at what were the primary outcomes that are really important to them, and it was about time, how best can they utilise that time, and life participation as well. So it was like time, out of hospital was a really big thing, time with family, and those things are really clearly valuable, not just length of time. It was about quality of life, basically. So that was really important. So we know that that's important. It's not just about survival. There's other things that are just as important. The other thing is that there was new information about health outcomes, personal burden, different treatment options. And that was really a research project that was informed. It was called the CKD Link trial, basically. And I think, Mathew, you were involved in that as well.
Yeah.
It's been going on for about 17 years. Is that right?
Well, yeah, not directly, but I have been peripherally involved in that one. It's been going for a long time.
Yeah, it's actually basically, correct me if I'm wrong, it's about, they use a lot of clinical data sets that collect information, pathology tests and other different things, and they link them together. And and honestly, we can find out, I think, a lot of information about 88% of the population. Yep. And actually they found, when they looked at the specific information about kidney disease and those that started dialysis and those that didn't, they found that yes, those that started dialysis did have a lot more survival. They did live longer. However, when they actually took into account how many days they were on dialysis and how many days they were away from their family, and I think I can't remember. Sorry,
how many medical appointments?
How many medical appointments? So they found that there wasn't actually a lot of difference between time that was valuable to them. So the time away from all of those things was there was not a lot of difference when you looked at those all of those things together. So this sort of, and when you actually get to the very old clients, you know, and we're looking at, I don't mean to be offensive, but 85 plus, there wasn't actually a lot of difference at all in survival and all of these other things, whether people had dialysis or not. So they're the really significant things that we found. This is new information. And so what we needed to do was actually look at how we can present this information, what's clear information that people need. They need this information to be able to work through their decision making. And me, as my role also as an educator, we'll find it's really valuable to be able to have these tools, these decision making tools, to be able to help people through that decision making process. So what the project is, what we will do, is we wanted to find out what new information should be included to support decision making about their care, and how consumers want this information shared with them. Because we can sit there and spout all this stuff off, but it's really scary for a lot of people. And so we want to make sure that that information is really relevant to them. So we also wanted to develop new and modified existing decision support tools and evaluate the benefit of those tools. So that's what the project's really all about. So we've got consumers right in the middle, and they are definitely the centre of this project. They're involved with every single step that we do. The phase one is we wanted to identify new information that's critical to share with consumers and health professionals. And that was involved focus groups in the north and the south, and also health professionals as well. So there were about 4 focus groups to actually look at this new information and really pinpoint what was actually critical to be able to use. The second phase is a co-design with consumers and health professionals. So we're coming together, not separate, together, to review existing decision supports, resources, and identify gaps in communication process. So this is really important that it's a together, and so we're doing this together with consumers and everyone involved. The third phase is where we're developing the decision support resources, and then obviously the fourth is to evaluate them to actually see how effective they are. So what we've done, we've actually completed phase one. We've done the 4 focus groups with the consumers living with kidney failure, their carers, supporters and health professionals. That's being looked at the moment, and the key researchers are actually not in Tasmania at the moment. So I believe they've done that when they're off enjoying themselves, which is good. And so the next step is when they come back, is we're going to be doing the co-design workshop, and we're going to bring everyone together. So that's really exciting. So the key investigators are Professor Mathew Wallis, Dr. Kim Wallis. So they're both Mathew, probably some of you know, is our head of department for the renal unit, and Kim works very closely with the Menzies Centre. She's one of our major clinical leads at this project. Associate Professor Rajesh Raj is a nephrologist in the north of the state. Professor Jan Radford is also in the north of the state, a prominent GP, and works also with UTAS, myself and Caroline. So that's us.
Thanks so much, Lisa. All right, we'll get back into doing some extra stuff. Yes. Right, so it's not over yet, folks. So now we've got a little bit of time up our sleeves if you've got some questions. But before we do open it up to you, I just want to point out that our lovely panel are not here to provide specific medical advice. So if you could please keep your questions general in nature, that would be great. So if anyone has any questions from the audience tonight. Yes?
Thank you for that very interesting information. How many people are actually on dialysis in Tasmania at the moment? And are certain elements of our community represented more highly than others, such as the Aboriginal community? We hear a lot about the very high proportion of people on dialysis in the Northern Territory, for example.
Yes, actually, that's absolutely correct. In the Northern Territory, yes, definitely, and I think Western Australia and South Australia also have, and Queensland, our northern, most of the states, but we don't here in Tasmania, but certainly it's significant. And the best thing is that there's been a really dedicated health strategy management plan specifically for our Aboriginal and Torres Strait Islander population that specifically targets the future and strategies for actually their healthcare, and that was done through Kidney Health Australia as well, and that's very recent, and that's really good. But to answer your question about how many people, I know in the south of the state we have 71 on hemodialysis and about I think about 10 or 12 on peritoneal dialysis. And I think there's about 100 or so transplant patients in the south. In the north have actually seen an explosion of people on dialysis, such that they are in a tighter situation than what we have. I think they have about 125 people on hemodialysis and about 40 people on peritoneal dialysis. But I don't think they have as many transplant patients in the north of the state as what we do. Yeah.
And there's no shortage of machines?
No, not currently, yeah. We also like to promote to home dialysis as well, so we really, because that takes people out of the in-centre type of thing in their own home, and lots more flexibility involved with home dialysis.
Thank you.
Yeah, we do. In terms of shortage of machines, they're very tight for space up in the northwest, and I believe the Premier has released some funding for them to build a new unit up in Burnie, and they have problems because they don't have nephrologists there. They have to source the nephrologists from Launceston, and of course Launceston have a lot more people on dialysis and in the pipeline coming through, so it's almost like a tsunami of demand and need. It's going to start in the northwest, it'll go to Launceston, it'll eventually come to Hobart. What we already see down here is that when Launceston have complex patients, renal patients, they are sending them down here for care, for dialysis, because they just don't have the resources. So, yeah, we're not short on machines, we're tight of space and people to look after and
staff.
Yeah, a lot of staff. And certainly Hobart, we have trouble attracting nursing staff to work in renal. I'm not sure why, it's a great job. But we think it's because we're out at Newtown and we get a little bit forgotten about, and we're in a cruddy old building, which hasn't been identified for redevelopment yet for us, but we keep our consumer group, our Hobart lobby group of people with kidney disease, are working hard to raise the profile that we do need better facilities in Hobart, because they're old and you get stuck in the lift going to dialysis, which is not good.
No. Yes.
A few more.
Sure.
Oh, you're right?
Yep, you go.
So 30 years ago, I was diagnosed with a kidney disease and told that I'd need a kidney transplant by the time I was 50. That hasn't happened. So I no longer see anyone at the Royal. My doctors take care of me. But how do I get to see you for like a care program or moving forward?
GP referral.
Yeah, you could ask for your GP for referral.
So a referral to...
Yeah. Well, it would have to come into the kidney health service, and if you're specifically asking for some education, maybe that could be in the referral. Yeah. The other thing is Kidney Health Australia. You can actually access Kidney Health Australia, and they have a really good education online process. Have you seen that?
Yes, I have looked at that several times. I just feel it makes me more accountable when I have someone that's
awesome
overseeing me and but
Like
okay.
Feeding
I'll
me
do
to
that.
a nephrologist.
Yeah.
The GP can do that.
Yeah, that's right. And we're also actually recently running something called the Get the Most Out of Life program. It's a chronic disease self-management program, and it can actually be attended by anyone with a chronic health condition. So that could be something also that you might like to keep your eyes out for.
Yeah, okay.
And you'd be more than welcome to come along to one of those without a referral.
Okay. Perfect, thank you.
Yeah.
Does kidney disease qualify under VAD legislation?
Oh,
I don't think
I don't believe, now they're working, we've got a palliative care, a renal supportive care nurse who's been doing a lot of work discussing that very issue with voluntary assisted dying people. It's my understanding at this stage it doesn't, but they are exploring that because it's quite
Perhaps
complex.
borderline? Could it be regarded as being borderline or?
It
No.
could, yeah, I think that it depends on each circumstance. But we are trying to get a little bit more information around that and how it would work. I think in time it will be.
It depends on the terminology of it.
He's an expert there.
I'm not an expert, but it has been raised, and it's about the nature of each of the different comorbid diseases or whatever, and the timeline, and that's the one that's the real bugbear with medical profession, because it's very hard to diagnose what length of time somebody may or may not. So it is one that will be raised again in the reviews out in 2025, where it will be more closely looked at with input in from the medical profession, I believe.
I agree. I think it is the timeline that is the critical thing, because kidney disease is in itself, people can hang around with kidney disease for quite a stretch of time, especially if it's nice and stable. So it doesn't fit. I think there's a certain time frame, 6 months or something like that. Yeah. So everyone's an individual.
Thank you.
There's one at the back.
You talked about diabetes. Is there any difference between type 1 and type 2 in that 40%?
Yeah, absolutely. When you look at that, the ANS data, which I talked about, does actually define how many people percentage with type 1 and how many percentage with type 2. Type 1 percentage is a lot smaller. So, looking about, of that 40%, it's only probably about 5%. Most are type 2.
So there's lifestyle.
Yeah. And genetics. Genetics and lifestyle together. They interact.
So we can't change our genetics or our ethnicity or our age.
No. But there are the lifestyle things, perhaps there is some room to.
What can you do to not have to come and see you?
It's to do all the things that we kind of already know what to do, and that's maintain a healthy weight, lose weight. It's to do a little bit more exercise and do it regularly. It's to quit smoking if you are smoking and don't take it up if you're not. It's not doing vaping. It's limiting your alcohol. It's controlling your blood pressure, and again, there's a genetic component towards that. If you've got mum and dad who both had high blood pressure, fair chance you're going to have it. So what can you do? Probably take your medication as prescribed by your GP. The number of people that get prescribed antihypertensives and don't take them. So regulate, control your blood pressure. Do what you can in terms of those basic lifestyle factors.
So in terms of giving up smoking,
Yep.
and when they say, if you give up smoking after X many years, you're back to being like you never smoked. What's the deal with kidneys? If you give up smoking, what's your time frame to start seeing benefit?
I would say it would probably affect the blood pressure first.
Oh, sorry, yeah.
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 No, the blood pressure control is really important, right? And chronic kidney disease is small amounts of damage to the kidneys over time. So if you halt the progression at a point in time, then the kidney function should remain relatively stable from that point onwards, theoretically speaking, right? And while there are genetic components to type 2 diabetes and the high blood pressure, if you control the blood pressure or control the diabetes, you control the diabetes. Those genetic components are, in a way, part of the risk factors for developing high blood pressure or having high blood sugar levels. And controlling those two factors, irrespective of whether you have the risk factors or not, makes a difference. So it's still important to do and still does make a difference. So it's not easy to do. gone.
No.
Do you effectively stabilise at that point, or can you recover?
Yeah, if that's the etiology of the kidney disease, it can stabilise it. Just imagine all the reason. It is more complicated than this, but for simplicity's sake, if the reason that the kidneys are losing their filtration units over time is because of fluctuating or high blood sugar levels, if you eliminate that, then theoretically you should stabilise the damage to the kidneys.
Yeah.
It is more complicated than that. I'm so glad Matt Jost isn't here today.
Yeah, we'll drop him in it when he comes home.
Question.
I think also just to answer your question as well, the earlier people get diagnosed, the better it is, because you have that opportunity to be able to make sure you're on the right track, to make sure you're on the right medicines, so you've got that opportunity to prevent that progression down.
Thank you for your presentations and your information. Is it always chronic? Isn't it acute first and then fall into chronic, or can chronic ever get better? You've half answered that now from what you've just said.
Yeah, now that's a good question. Yes, you're right. There's something called acute kidney injury, and there's also chronic kidney injury. Acute kidney injury is something that happens really suddenly, and it can happen for various reasons, but it's generally recoverable. So it happens quickly and it can recover. Chronic kidney disease is something that you've got permanent damage to your kidney. So we usually try and prevent progression down with all of these things that we've talked about to slow that progression down. But it can't regenerate most of the time when you have a chronic kidney disease. So it's about looking after and preserving what you have.
Right, thank you. And if I may, do you have, where are the other major research areas in Australia that you would get support from with all this work that you're doing, or you would interact with, or, some of the, Monash, Sydney, or Garvin, or somewhere like that?
I think all the major hospitals, absolutely all the and they all have research foundations attached to them. Yeah, I think.
But specifically for renal.
Oh, for renal. Oh.
Yeah. Again, that might be a bit more of a Matt Jost question.
Yes,
but yes, my understanding is all the major hospitals have a good renal service, and most tertiary level medical specialty services have a component of what they do is linking with research. What the component is and which hospitals have the highest renal research components, I don't know the answer to that.
Actually, yeah, I know Professor Jost is heavily involved with a lot of research and a lot of different things, and but there's also something called, I think, CKD Beat, and that's actually a really good thing, and I think consumers also are involved with that as well.
It's the University of New South Wales or Sydney University?
Sydney University, and so they're very active in trying to recruit consumers and people that are involved with kidney disease into research, because it's vitally important that you're involved.
Thank you.
Excuse me, CKD what? Beat?
Beat.
CKD Beat. That's just the name of the
Beat CKD.
Beat CKD. Or is it? Or did I get around the wrong way?
No, I think it's CKD.
Yeah. If you Google it, I reckon it'll come up.
Also, you mentioned the name of a drug. You're talking about improvements. It sounded like a group of...
Yeah, Flozin. We call them Flozins, but...
Could you spell it, please?
Pardon?
Spell it.
It sounded like you're saying frozen.
Flozin, Flozin. Flozin. So it's like things like dapagliflozin. You know the actual trade name? No. Dapagliflozin and epagliflozin are the ones that have actually come... They're also commonly known as SGLT2 inhibitors. So they just act in the kidney a little bit differently, and they help preserve the flow through, I guess. It just takes the pressure out of the kidney, and it's been really good.
That's really interesting. Was it be on the glomeruli or the...
Sorry?
What is that?
What's act on the in the kidney itself.
Yeah, it works in the kidneys, so it stops those little receptors in the kidneys.
Like receptors.
Yeah. So SGL2 inhibitors.
Thank you.
They're mainly used initially in diabetes, so it actually helps the kidney actually get rid of sugar. And they found that with all the research, it actually helped people with kidney disease and people with heart disease as well.
Wow.
They're really miracle things. Oh, I probably shouldn't call them miracle things, but they've been very good.
That's very interesting. Thank you.
Yeah.
Just one last question, or a couple of last questions, yes?
I was just wondering, what's the youngest person down south that you have here on dialysis, on regular dialysis? What's the youngest person? And I'm asking that for what does their life look like with dialysis? What options do they have as they continue the path?
Yeah, look, a young person, they should be looking at transplant. So we try and avoid dialysis for our young ones at all costs. Really, their goal should be transplant. So.
And does that occur here in Tasmania? Do they have to go to Melbourne or somewhere else for that transplant?
Melbourne. Transplant's always in Melbourne. Yeah, and our younger under 16s, under 18s are usually managed with the Royal Melbourne Children's. So we don't usually dialyse people. We did have a young child here, and she was dialysed for a little while, but we didn't look after her. She was actually managed through Melbourne, and thankfully she had a transplant.
And what numbers per year are we talking about transplant-wise from Tasmania? Is it
for Tasmania?
Or 20
No, we've had about 5 transplant for people gone for transplants this year already.
That's just Hobart though.
Oh, that's just Hobart?
Yep.
Yeah.
Thank you.
Yeah.
There would be a couple more ones
So
as well.
always our gold standard, and where we would like people to be, if they can have a transplant, we want them to have a transplant. So it's usually pretty high up, and in our care and education, and because we see that as the gold standard. But not everyone, unfortunately, can have a transplant. So yeah.
Thank you.
And I think we've got time for one last question.
Just with transplants and creating organs, so is there anything going on with our porcine mates? Are we doing anything there to be able to put their kidneys in us?
A lot of that's in the clinical trial or even before the clinical trial stage. But yeah, it's one area of promise is the kidney in a dish, in that you can get patients' own stem cells and tell those stem cells to start making kidney cells, and then ideally at some point that might not look exactly like a kidney. It might be cells that grow on an artificial scaffolding that are then implanted. So that was those 2 scenarios we were talking about earlier. And the place in the middle is what it might actually look like, in that there's some scaffolding and patient cells that have been reprogrammed to look or do the function of a kidney cell. So that stem cell research and creating those artificial kidneys, that's come some way, but it's still in the research space and is some way away from being in the clinical trial phase. So
We're not doing anything with pigs.
I mean that happens, but I don't know as much about the pig transplants, but I imagine it's actually more tricky because it's a different organism, and the body is much more able to recognise it as not being, appropriate, being foreign, and targeting it. So a lot of the issues with transplants, as some of you might know, is rejection. So that's why they try to match the donor so that the donor that's implanted isn't targeted by that patient's immune system. If you implant something from another organism, it's so much different to what's there in the first place. It'll get rejected, or it's a lot more likely to get rejected. So then you'd have to trick the pigs into making a kidney that was like the patient's kidney. And to get to that process is actually harder than the kidney in the dish process, most likely.
All right, well, thank you all very much for coming tonight. That's about all we've got time for. Once again, thank you to our incredible speakers. You were a wealth of knowledge tonight, and thank you for answering our audience's questions. we put these wonderful events on for you guys free of charge. So if you do feel inspired by what you've heard tonight, please feel free to head to our website, rhhresearchfoundation.org, and make a donation to the cause. Thanks again for coming. We have another event coming up on the 24th of July for Pain Week. I'm not sure if any of you have any pain conditions. We've got some wonderful speakers with Felicity Veal and Gregory Peterson, where they'll be talking about pain management and even talking about cannabis for medicinal use. So it'll be a really interesting topic. So feel free to come along to that. Yeah, I think it'll be a really fascinating conversation. So thanks again for coming along, and we hope to see you there. Thank you.